the issue that has congregated us tonight, all right? Is SHA the solution to Kenya's healthcare challenges or not? Now, there's many ways to go about this, so we'd like to be a bit sequential on how we get to it. I cannot guarantee we'll discuss all the problems that SHA has and all the opportunities that it has delivered, all right? I'll also see the good parts of what SHA has done. But let's just set this in this manner. Let's look at what Kenya Kwanza administration, what they set out to do, all right? So first, the biggest problem when we talk about healthcare financing and finding a universal healthcare, we have to acknowledge that there's no country in the world that has gotten it correct. And it's going to be on your screen anytime now, that the Kenya Kwanza administration, they said that they have to think about the universal healthcare, which is anchored on 3 pillars. One is a fully publicly financed primary healthcare: preventive, promotive, outpatient diagnostic, choice of public, faith-based, and providers. The question here is to figure out how does the entire public pay for our healthcare, because we all have to use these facilities. So it is at the base of how we think about healthcare financing, that how do we exactly finance our healthcare, and everyone has to pay for it. Then there's the question of seamless universal healthcare insurance, private insurance sector, National Fund for Chronic Catastrophic Illness, so that is cancer, diabetes, stroke, accidents, pandemics, financed by insurance levy and government funds. So there's the second part of it, which is the health burden that we have. Chronic illness have to have a fund on its own, so that sort of we sequester and say, okay, we need maybe 50 billion, whatever billion, to deal with the cancers, you know, HIV and AIDS, things that are chronic and they're in our system, all right? And then I think there's a final one this is actually now on your screen, on exactly the difference on NHIF versus SHA, okay? So on NHIF, the mass contribution was 1,700. SHA, 2.7% of payroll deduction, that is formal workers, or the famous people with pay slips, are the ones who are paying this 2.7.5%. Informal sector, 2.75% of household income, about 300 shillings, and this is when I started getting into murky waters, you know. So how do you actually going to get this? You know, I'm a jua kali worker, you know, I don't have a payroll whatsoever. You can't force me to pay my 30,000, 2.7% of my 30,000. Anyway, we'll have, let's, just in order to set up what the president said, I think recently, on the question of the SHA contributions, because it really helps us to layer on the basic conversation of how do we set up a fund on how we pay. I don't know if you've got the clip, but we'll come to it. But let's just get the panelist view. Let me start with Latif. There's the last one. I think there's been, to be fair, from a government point of view, that this is a new system. It will have challenges and problems, and we have to give time for a policy such as big as SHA to find its footing. You know, it will have challenges, to have problems. There's questions on how, you know, we understand as a public what governments have to do, and so it's a bit unfair to expect that SHA would hit the ground running. Is that a fair assessment? No. A fair player? No. I've raised this issue as one of my hot buttons in previous weeks, and saying it's all about rolling out a program, project management, and understanding what you need to do along the way. So, yes, the administration came into office with a promise that we are going to have universal health coverage. Uhuruto 1 and Uhuruto 2 stroke handshake had tried it. They did trials and, you know, 4 counties. They never really told us the results of those 4 counties and so on and so forth. So this one came in and said, we are going to try and do it differently. Prepared bills, took the bills to Parliament, you know, steamrolled Parliament. Parliament passed those bills very fast, and the president actually said, it was on Madaraka Day, one of those in Kericho in 2023, where he said, so now we have all the laws in place and we are starting SHA. They had 1 year at least to work on the transition. In that 1 year, conversations kept happening on what exactly are you doing to prepare for the transition from NHIF into the new system that is universal health coverage.
how many, and we have some stakeholders in the room, how many stakeholders were actually called in and told, this is what we're working on, what would you give us as your input in starting this? That is representing the healthcare providers, both private, faith-based, and public. That is also thinking about the main client, the contributor, the patient. That is bringing in other experts on health. So how do we roll this thing out? That is bringing in financial institutions and so on and so forth. How do you provide ability for people to contribute? All these conversations ought to have been happening. But what I remember clearly hearing was the cabinet secretary then for health saying, SHA, NHIF, NHIF imekuwa corrupt, tunafunga NHIF, tuende kwa kitu mpya inaitwa SHA. I feel that they mismanaged the rollout of SHA. They ought to have done a lot more in stakeholder engagement, a lot more in communication, so that by the time we are starting, even if we started in September last year, by the time we are starting September into October 2024, more people would have heard and understood what it is. And then said, we are rolling it out in phases, and these are how the phases are. We don't even know. This thing is actually being rolled out in phases. But not many people know what the phases are, what the milestones are, where we get into it. It's a brilliant idea, poorly managed.
Brilliant idea, poorly managed. You have a placard or a board that we gave you, red and green. All right, did everyone get it, or most of you? So let's do the most scientific poll ever invented in the history of science and opinion polling. So green is SHA is working, red is SHA is not working, all right? So I'll ask the question and then just put it up as high as you can, all right? It's scientific, by the way. Is SHA the solution to Kenya's healthcare challenges? Use your board. For if it's working, it is green. If it is not working, it is red. My goodness, this is it's a good opinion poll. I hear it is a bit of green, it's a bit of red, quite some reds in the room. Let's.
So the question is whether SHA is?
Yes. Is it working?
Is the solution. Honestly, guys, I'd rather have
Is it SHA the concept or SHA as it is now?
As it is now. What we've experienced. what we've experienced. I mean, I think we'd have time to discuss the policy and those things, but I think what we've experienced in SHA with the challenges that it has, right?
It's so ambiguous. You know, again, as a Gen Z in the room, by the way, cut me out because maybe I've not gotten to that age where I require health services like crazy. I think I've been born into an age where health is such.
What are you suggesting?
Just saying. NHIF era, I had it from my parents, how the complaints were. But anyway, you know, making health an authority is also a challenging concept that I still want to understand. SHA is an authority, right? So what it does is that apparently it pulls together fundings towards healthcare in the country, which for me is ambiguous because you have 50 plus million Kenyans with very diverse and different health issues and health precautions. And the chronic illness fund is also, for me, I have so many questions because again, isn't it immediately after SHA started that we had cases of people who are outside the country seeking medical help that couldn't access SHA that are fully paid for? Also for me, I'm looking at the fact that when we were transitioning from NHIF to SHA, there was billions of Kenyan shillings already put in NHIF. Where did those billions of shillings go and how did it translate to SHA? Equally, when we're looking at the predominant accessibility prospects of SHA, I'm looking at places like Turkana, Mandera, Isiolo, where maybe, first of all, the hospital is almost to the brink of closing. There's stock issues when it comes to drugs. I don't know where KEMSA went, by the way, and we won't get there.
Having the fund for the emergency and critical and chronic illnesses, whilst there have been those challenges, do you not think that that expanded benefits package is by itself in the design of this framework
I feel like
a win.
Sorry. I feel like it is a win, but appropriating it under SHA is questionable. Looking at the fact that I think when we see chronic illness, of course we dive into cancer, we dive into things that are a bit more common, dialysis. Kenya has a big array of chronic illnesses, including illnesses that are not necessarily treated. I feel like financing is at a level in the world where it's so developed. So when we bridge financing into one pool that we already know, Kenya has a tendency of fraudulent practices when it comes to financing. I think exposing the Kenyan health sector into different variations of financing would better bring health to Kenyans than having SHA that is not actually speaking to people.
So you have a problem with the concept that is SHA, the way it is set up?
Yeah, even the name.
All right. Okay, before I come here, let me just get some. Hopefully, I didn't get your vote, but let's start with you, because you obviously deal with these questions frequently. 1 year on, is SHA the solution to our healthcare challenges as a crisis nation? So please introduce yourself and go for it.
Hello everyone, Dr. Tim Theory is my name. I serve as the Chief Executive Officer of Kenya Healthcare Federation. The Federation is the apex body or the umbrella body for the private sector actors in health, and we overlook the entire value chain. And I'd want to say we have an excellent view of what is happening. Straight off the blocks, I'd want to take us back to the constitution that Latif was reading. And the preamble says, we, the people of Kenya. And there are a few lines, and it says, commit to nurture and I think the well-being of the individual, the family, and I think community and the country. That's what Kenyans wanted for themselves. And in the Bill of Rights and the economic and social rights, the first thing is about health, the highest attainable standard of care. That's what Kenyans wanted for themselves. And this constitution has implemented a mechanism through which Kenyans get this, and that is through their government. So government remains to be the agent through which Kenyans get to achieve what they wanted. And until we make it politically profitable, even for bad people to do the right thing, we'll still remain in trouble. And no country has leapfrogged like we want to without a plan. So the first thing we need as Kenyans is a blueprint for healthcare. We don't have one. If Latif today wants to become a governor in Nairobi and he has a cough that can't go away, he will focus on the chest. And Sharon comes in later and all she wants to do is to be beautiful. The next thing we'll be having is a focus on what? Plastics and cosmetic work. We don't have a plan. That is just the truth. So we need to go back, create a blueprint for healthcare that both sides of the political divide and we as Kenyans can agree on. So when it comes to SHA...
What would this include? Like, is it infrastructure? Is it the...
It is a wholesome plan.
One could,
It's a wholesome plan. So we would start all the way from health systems, human resources for health, HRH, and that is why I've always been a big proponent of the Health Service Commission, and that is something that we must look to implement. We come to infrastructure and say this is the kind of hospitals we want to build, this is how we shall structure them, this is how we shall tier our care, and then thereafter come and say this is how we are going to finance it. This is our third step at UHC. But UHC is a journey. What we have right now is an attempt at affordable healthcare. And those two are different. The pillars through which the current administration is attempting to do this is through healthcare financing, digitization of systems, primary healthcare, and commodity security. Those are the three pillars. Now, SHA is an insurance scheme, and it is not immune from the physics of the principles of insurance. And the first one of them is utmost good faith. So the government has said, We know our people. These are the diseases that Kenyans suffer from. We have quantified them, and I think we can pay for them to this extent. So we have a payer. We must come to the people who provide the care, that is the hospitals and the clinics and the doctors. So we have a provider. And we do have the people who come to seek care. So we at Kenya Healthcare Federation, what we try to optimize is that relationship between the person who seeks care and where it is provided. So that triad is often an unhappy one because when one of the parties is happy, the other one is unhappy. However, SHA in itself is a trust and a social contract that the government has with its people.
All right.
And I'll just go to my final point, and that is, as long as we do not have trust in that relationship, then we do have a problem.
I have a question.
Yes.
And the good thing about this show is that we have to find that last one. So,
yeah.
Especially because you represent a federation that I think is equally important.
Yeah.
So remember, you're in a country whereby all our nurses and doctors are being shipped away according to the government plan because that's a better idea of creating employment. So looking at the fact that there's already a gap in terms of healthcare service, and the WHO guidelines for universal healthcare looks at the 6 building blocks around financing, leadership and governance, health information system, medical products and technology, health workforce and service delivery. Do you think SHA answers anything? And it's good you've mentioned it's an irrigation, licensing, whatever scheme, which I think is phenomenal because it is. Do you think it's a system that Kenyans actually require? Was it immediate necessary? Is it an actual assessment to affordable and accessible healthcare or not?
I think SHA attempts to answer the question of who finances healthcare.
So
there's no free healthcare. So someone has to pay for it. All right? So Kenyans have underwritten this risk to government, and government came up with SHA. Okay. So who is SHA working for? All right? One, we've seen it work well for oncology patients, that's cancer patients. We've seen it perform decently for renal care, dialysis care. Medical inpatient is pretty okay. Surgical procedures, patients are fairly okay. Now come to the other side, who doesn't it work for? Now once a pre-authorization has been given, the Kenyan gets the service and they go. But providers are left to deal with the logistics of that. And so for example, when a procedure is declined or a claim is declined, then there's no way you're telling that provider that it is working. So those are some of the challenges that we are seeing. Are they solvable? My belief is yes. Because
I want to come to that because the question of financing is massively important because we are all not paying to this system even if it works for a few and then there's a problem. But the lady in red here, where's the microphone? She said SHA is working excellent. There is absolutely no problem. Please just move that microphone to the front before I take the break. Please.
All right. Thank you very much. My name is Dr. Elizabeth Gitao Maina. I come from Kenya Medical Association, the umbrella body that represents medical doctors. SHA as a concept is actually a good concept. And whether you know it or not, we all want SHA to work. Whether you know it today or you'll know it in the future when you require the health services. SHA provides an opportunity for us to prepay for healthcare. As Dr. Tim says, there's no free services. And the concept of SHA is to ensure that everybody has access to health services without facing catastrophic health expenditure. That said, it provides a hybrid mechanism. And that is what primary healthcare was supposed to come and do. That you provide free healthcare paid for by your taxes before you get sick and to all Kenyans. It does not matter whether you can afford or not. Yeah? Yeah. That communication, however, is faced by many challenges. Yeah? There's a shift issue where people are afraid of means testing. There's a perception of formal workers that you're paying too much. And there's also the other challenge where you have not...
Reality?
Pardon?
Say the perception.
It depends. It depends with who you are, yeah. So there are people who earn 20,000 shillings, and in fact, their premiums reduced, and there are people who earn more than that, and their premiums increased. Yeah. So in terms of equity, when you look at it from a health financing and economist perspective, when you provide to a flat rate of a percentage of income, you actually provide equity. Whether it should be 2.75% or 1%, that's a question Kenyans can come and say that we probably want it to be 1% based on what we are able to afford at that point. However, we go back to primary healthcare. The building blocks, as she has rightfully mentioned, you cannot have a health financing mechanism where you promise healthcare services, yet if I cannot access Panadol at my health center, then what are you paying for? It means that the promise that you gave me as a government, that when I go in, I'll be able to access health services, must be met by qualified health practitioners at the facility, must be met by commodities which are available. Then I will buy that promise that SHA is working. When it comes to on the provider side, where is it working? On the provider side, SHA actually has implemented digitization, which enables providers to be contracted easily. Previously with NHIF, you had to go back and forth with your lawyer's legal team, contract, etc. These days, you're able to do e-contracting, and as long as you're licensed by your regulator, you're able to get in quite easily. When it comes to you as a patient, what SHA provides for you, and I think Dr. Tima will not repeat what he has said in terms of the areas in terms of chronic illness or the areas where you're able to access surgical services or let me even come to surgical services. Previously, NHIF used to pay a rebate when you go to our private hospitals. Currently, it has actually defined a benefits package that when you go to get this surgery XYZ, if you go to Nairobi Hospital, I'm going to pay 40,000. If you go to Mama Lucy, I'm going to pay 40,000. So it is very clear to you that you can access health services anywhere. Of course, there are multiple challenges. When I say it's working, on concept, it is working. However, there are significant implementation and operational challenges that are making the dream become very risky. Because when you do have providers who, one, have legacy debts from NHIF, you have problems. Our doctors have not been paid by hospitals because of the claim that SHA has not paid them. Secondly, you have claims processing that significantly was expected to be faster. It was expected to be more efficient because you're using digitization by the DHA. However, you're having a situation where providers are unable to solve certain challenges when it comes to a rejected bill, or when it comes to if my claims have taken so long to be addressed, you're having a situation where SHA does not have the human resource capacity to be able to quickly resolve your challenges. And that is why you're having the standoff between providers and SHA as to give me my money, I provided services. Yeah. And on the other hand, SHA is saying, I am paying my bills. And it is because of that lack of trust. If you have a system, you can have the best ICT system in the world, but where trust is lost, you're having a problem. And finally, to my last point, on the Kenyans, the promise to Kenyans that you'll access health services, and I need to trust the means testing. If the Kenyans do not trust the means testing, then they find it difficult to actually be able to sign in. Surprisingly, SHA has actually gotten a lot of us Kenyans to sign in. We have an increase in the number of Kenyans who have actually enrolled to SHA compared to NHIF. So it means Kenyans actually want some level of protection. However, we must make it easier. We must provide some level of social protection mechanism that is extremely clear, that I don't have to know my MCA, I don't have to know my MP to get on a list. And all governors must come into play. I think sometimes we are not cognizant that we have 48 governments in Kenya, that you can have a national agenda which the COG might not be as fast enough to adapt to it. So you're having indigents in the counties who might not have onboarded onto SHA because either that is not a priority for that particular county government. So there are many things that SHA can improve on for it to actually, then we can go full green light and say that SHA is a solution to the health financing question.
All right, I need to take a break, but I'm always fascinated by this one thing about the number of people who are getting into SHA. It's also a fascinating concept because I don't see the same number of people who are fascinated by trying to pay for SHA. That number really never increases. It's just like, oh, we have 21 million. I guarantee you can get up to 50 million. But the number of those who are paying would remain the same. So essentially, you're running a system on deficit. And we've never been able to answer that question. Taking a short break. When we come back, we exercise our minds on how to deal with those problems. Is SHA the solution to Kenya's healthcare challenges? You're watching The Last Word. Don't go too far.
We're going to have something like 90 billion every year. From our own resources in equipment, we have mobilized, we have designed innovative, creative mechanism of delivery of equipment. We are now taking equipment to hospitals worth 200 billion shillings. Not equipment we have paid for, equipment we have structured, how they are going to deploy their own equipment, we pay them for service, and we make sure that we deliver health. So we are mobilizing close to 300 billion shillings using our own money, using our own intellectual capacity to deploy and to provide health to our citizens.
A simple thing that we have come to realize after 1 year, and that is that the SHA financing model is unsustainable. SHA is broke. This is despite collecting 2.75% from the gross income of salaried Kenyans. SHA has been unable to collect from the informal sector. Today, SHA...
Welcome back. From wherever you sit in this divide, 200 billion, 300 billion of very well-structured health financing to, well, this thing does not work, it's broke. There has to be a middle ground, surely, somewhere here, or otherwise we live in a world that doesn't belong. Let me just start again here just to get this. Are we getting close, or we're just doing the political questions that we always do, that, you know, everything is possible but nothing is real?
Thank you. Thank you, Smart. My name is Peterson Washira. I am the National Chair for Kenya Union of Clinic Officers. I'm also the chair of the Health Caucus that brings the health unions together. And so today I'll be talking as a health worker, but also as a recipient of the services, because the people that I serve, at one point or the other, themselves or their relatives, including myself, then we become the patient. And I must say that the problems that we are seeing now is as a result of political bad manners. I remember when the 4 laws were being developed, we participated in terms of public participation. My colleagues who are seated here, all of them, I can remember them very passionately. We went there and we tried to inform the drafters technically on how they could make these laws better. But then, after we were called to State House, we witnessed their signing. Later, in one of the political podiums, I remember the CS then, CS Nakumicha, stood there and actually thanked the members of parliament for having passed the legislation without even changing a comma. So we have politicized policy, and we no longer reason to technical reason or voice of reason. So what am I trying to say? The problem that we're experiencing now, and it's good that I draw contrast between the manifesto of the Kenya Kwanza, the midterm plan for the Vision 2030, which is aligned to the better plan, the bottom-up economic transformation agenda, and the SHA that we're having in terms of health. If you look at the manifesto, it actually talks about prioritizing primary health care, and even goes ahead to say that every 1 shilling you use in the primary health care, you save 9 on the other side of the curative. But what are we doing? What we have currently, the funding model that we're having with SHA currently, actually prioritizes secondary health care, curative health care, over the primary health care. And if you want to know the priority of the funding model, then look at the amount of money we are putting in. The primary health care, because we have different funds. We have the primary health care fund, I think some 12 point something billion were set aside for the same. We have the shift that you and I contribute into. And I think we were told about 133 billion per year. But that shift, the money that we contribute, can only be accessed from level 4 hospital, or the primary hospital, which is purely curative. So your priority is where you put most of your money. And so we are not actually funding primary health care. But then they go ahead and say that you cannot access level 4 unless you go through level 2 and level 3, which is the primary health care. So we take 100% of Kenyans to level 2 and level 3, but then that is where we fund least. And then where about only 15%, because 85% of the people will be seen at the primary health care level and go back home. About 15% of them are going to proceed to level 4 and above, and then we have 133 billion there. So then the question then lies there. Where is the priority? So what we are actually doing at the primary health care is that we are not preventing disease. And I had my sister here say that primary health care is about prevention of disease. We are not preventing disease. What we are preventing is we are doing secondary prevention, because primary prevention is actually preventing that citizen from getting the disease in the first place. But the community health promoters we have out there, what they are doing is actually scouting for people who are sick so that they do not get complication. But we do not have health workers out there. And we have experts. We have our public health workers. We have trained community health officers. We have health workers like nurses, clinical officers, who can actually go to the community, just like the model that we had taken from Cuba, and they can be able to assess families and communities, and they can be able to probably ensure that we have the primary prevention. So the reason as to why I'm saying that currently as it is not the solution, is because, as she rightly put it, we have about 6 pillars of the health system. So this is a financing model. But together with the financing model, and now that we brought in some other bills like the FIF that retains the money in the facility, that is going to probably sort now the supplies and the commodities. We have the Digital Health Act that is going to sort the information system. But then, on the issue of the human resource, on the issue of governance, it doesn't address. So we must go beyond SHA. And one of the problems is that we are preoccupied with SHA, that we are not actually looking at the other pillars that are very important. Right. No matter how much you are going to fund healthcare, if you do not have human resource in the right mix in the facilities, then you are not going to provide that quality service that you wanted to provide. Okay. So it is not a solution.
So for you, it's not working? Not working.
Policy-wise,
yes,
as the acts are, have been developed, and in the details of the act, SHA is the best thing. But in the implementation, that is where we are getting it wrong. And so as we sit here, it is actually not working.
Let me listen to Rupa, who the last day or two have said that they are taking it cash. Yeah. You're advising your members, yes. No more SHA. No more shisha.
Yeah, thank you, Smart and team. My name is Reverend Joseph Kariuki. I'm a facility owner, as well as the vice chairman of the Rural and Urban Private Hospital Association. You've rightly said, news went before me that we are not taking SHA. True. But let me start here and speak from the angle of a service provider. SHA is not working. And for even when you have heard Daktari here speak about how SHA is good, she's still talking about ideas and policies and things. While we are already 1 year into a transition from NHIF to SHA, we are already 1 year into SHA, and they're still talking about ideas on paper. I mean, tulipita huko. What we should be looking at right now is the whole circle of SHA. Is the client getting the service? Is the facility getting paid? Is the system working efficiently? That's what we should be looking at. Right. We are past ideas. We are past those other discussions.
Reverend, can I ask you a couple of questions?
Yes.
Because you are a facility owner yourself.
Yes.
Okay. So, one, was the onboarding onto SHA for your facility to be contracted by SHA, was it seamless? Was it better than the NHIF model? Secondly, the way you operate now, and patients are coming to your facility, and you're offering services, is your billing and payment from SHA working seamlessly?
We start with the contracting. This time, under SHA, we got it very right because it was all digital from end to end. We had to read the contract digitally. We had to sign it digitally. We had to, send it to SHA digitally, and that was very good, 100% for that. When it comes now to the claim system, that's where we have a problem. Because immediately SHA came in, that 104 billion thing failed within 2 weeks. And when it failed, they had to source another one, Slade from Savannah Informatics.
What does fail mean?
It failed to work. It didn't deliver. It couldn't do anything.
Practically, yes.
Yes.
As a facility owner, what does that mean?
It means
you lodge a claim and it goes?
Yes, and the process cannot go through.
Okay.
In fact, there was no way you could view even the movement of your claim. And so the other system came, the Slade system came, and that is what we've been developing as we work with it. We've been making it better, giving feedback, and telling them where it doesn't work, where it's working. And all that is what has gotten us to where we are today, at least better off. So when we talk about the systems in SHA, we are about 75% good.
So why aren't you offering services then, Reverend? If you're 75%, that's a good part.
That is good.
Yes.
This is where it goes. The system, why I'm saying it doesn't end well, it's because at a certain point, and that is at the payment point, it turns manual. There is human interference on it. That is why you can lodge a claim and don't receive the money at the end of it all.
Pesa inaenda wapi?
Pesa inaenda mahali ingine. We have heard about ghost hospitals. Yeah, we have had some facilities earning 40, 60 million, while other hospitals go zero. There is some payment that was made yesterday. Some facilities were getting 1,900 when they're expecting 3 million and above. So the problem that we have is we have never had the software right, but the hardware is good. We have the hardware working very well, but the software is very, very poor. So that's where we are as far as SHA is concerned.
Reverend, let me
Yes.
have a question for you and also to the rest of the panelists, because I feel like my mind is boggling through the amount of narratives we have. This country is full of stories. So I want to ask you, because especially you represent a voice that most of the time healthcare tends to suppress, which is the rural areas and facilities around that. Number one, so what does SHA contribute when it comes to community healthcare, where most communities actually have access to, that most Kenyans actually do trust, because we don't have referrals everywhere? Does SHA have an ultimate representation around community health services? We have churches that own hospitals. We have individuals, etc. How does that correspond? And to the rest of the panelists, for me, I think healthcare is very holistic, and I have a strong belief inside me. I'm a cognitive neuroscience student. So I know if Kenyans would remain healthy, the entire industry goes bankrupt. So we're not in the discussion around saying Kenyans are supposed to remain healthy. No, hospitals will not run. So in the reality that we are in an environment where people do get sick and things like that, I have 5 things that I feel like I'd want the panelists to reflect and maybe help me answer. We have disability rehabilitation and assistive devices. Are they occupied in SHA? Because they have consistently been inaccessible. We have SRHR and contested services, because I think abortion is also a whole thing, whether illegal or not. Sexual reproductive health is a whole serious case. Is it considered? Because I don't see a space in SHA because it's under prioritized. Maternity and reproductive health, I've had complaints of persistent OPP, OP payments in childbirth, where we moved from Linda Mama where we are at now when it comes to maternal health. And also, Kenya has a breaking issue with mental health. Where is it in SHA? Like, I feel like as we're looking at the universal coverage, we're looking at the fact that we want Kenyans to be holistically healthy. Just guide me on where that works.
My take will be this, and Daktari has already alluded to it. This system is is a referral system. And at level 2, level 3, that's where we are supposed to start our journey. And like Daktari pointed very well, that is where it is highly underfunded. You know? So for us to get to this other place, before you know whether somebody need a device or not, they have to go through that place. Yeah. If level 2, level 3 are not properly funded, level 5, 6 will do nothing. Will do nothing absolutely. So what we need to see in SHA and in the entire healthcare system is a properly funded PHC, which is exchequer funded. So we need to see government bring in a lot of money at level 2 and level 3 and the select level 4s, so that we can be able to tell whether level 5 and 6 are functioning well. So we need to look at this thing from the preventive first. Because we say when we spend a shilling on curing, we are saving 9. And that is where we need to go. But what is happening now? We are having facilities at level 2 and level 3 that have claims pending from January this year, February, March. We have others from December. Those facilities on the lower level are not being compensated as they should. And the community ones? Yes, that's level 2 and level 3. So if they don't get the money, they keep on diagnosing people and they don't get compensated, and they keep on admitting. They're the ones doing maternity. They're the ones running all these KP vaccines. You know, there is a big problem there. So we need to go back to the basics and say, can we fund adequately and stop delaying the money for level 2 and level 3s, because those are actually smaller facilities. So they need this money almost like yesterday. So we need to get to a place whereby we consider, and that's why as RUFA we are saying, if you don't provide money, we will tell you SHA is not working. Because it only works for the patient who has come to the hospital, be treated, and go home without paying anything. But the facility that has done that work, when we have not received money, we will tell you SHA is not working.
All right, Reverend. Thank you very much. I want to come back to this panel, but there's also the audience in the room, and they've been dying to speak. So I want to give them the microphone, then we come back. Just raise your hand. There's a gentleman here who's willing to speak. Just hand the microphone. I'll come back to him, and then I'll come to this side. So very quickly, so I can get more questions, ideas, and responses. Please stand up. Tell us your name. Is SHA working for you or not? Are you a paying member, by the way?
Okay, my name is Ibrahim Machera, and according to me, SHA is not working.
Do you have an experience of SHA not working?
Yeah. Why am I saying so? You know, SHA just transitioned from NHF. Of course, there is some things that it inherited, some debts, and of course, some cash. So I have got some questions, plus some things to speak. So if NHF was abandoned, so where that amount that it had went? And of course, you know, there is no way somebody owning a facility like that Mzee have just said, you can't come to my hospital, I treat you today for free, you go, I'm not being paid, and then tomorrow you come, I treat you, you go, the next day you come, I won't treat you. Of course, that leads to high death rates.
Right.
If I won't treat you actually you are going to die. And sure, you are going to die. And there is no way some hospital, in Kenya, there is a lot of things. In Kenya, you may find he has a facility, amepewa 1,000, and there is some ghost hospital somewhere, zimekuwa allocated some good amount. Now, if you follow up, you don't know who is owning those hospitals.
Okay.
Yeah.
Thank you.
We know.
Thank you. This side, Jen, please.
We know.
And then I want the lady to speak. Yes, please hand the microphone to this side. I need the ladies to speak. Yes. Your name and what is SHA working for you?
Okay, Turuka Samson from Migori County, Kuria West Sub-County, Masaba Ward. On my side, SHA is not working. From the rural areas, especially where I come from, I individually have experienced from the hospital of Migori Komasimo, whereby you go and queue there more than 4 hours, and at long last will only be being weighed for the kgs, na unaambiwa enda nunua madawa. Sasa unashangaa kwani SHA ni ya consolidation ama ni ya kupima tu kg peke yake. So I only wonder, last time even we see CS Ndwale akisema kama uko na hii hustler fund hata uwezo uka-access. Sasa tena shida imetokea wapi na hapo? So I only ask CS Ndwale, angalie SHA inahudumia watu kupima kg peke yake ama isaidie mwananchi wa kawaida? Thank you for that.
What's your kg? Don't answer that. On this side, do we have ladies in the room? I have a lot of... Yes, please. The lady, yes, and then the lady in front of you will speak afterwards. Please, go ahead.
My name is Miruka Christine. I am from Kisii County and a law student at JKUAT Current School of Law. As a law student, I'll first of all start by appreciating what is existing and then critique it, but not criticize it. So first, the government has ensured that the citizens have an attainable high standard of health by introducing Social Health Authority, that is SHA. And we see that is under the universal to ensure that there's a health care for the people. However, there are many questions that arise therein. In the laws passed to secure Social Health Authority, that is the SHA, we see that there are 3 funds allocated therein. That is under Article 20 to 30 of the Social Health Insurance Act. We see the Primary Health Care Fund, we see the Social Health Insurance Fund, and we see the Critical and Emergency and Chronic Illness Fund. And under these funds, the 2 of them are government funded. And therefore questions arise, is the government actually funding this? Is it ensuring this passes by? And therefore, this also brings us to ask ourselves, SHA was brought in to promote the digital health ecosystem. And this was seen in the arrangement by the government to the consortium led by Safaricom to ensure an investment in this digital health ecosystem, whereby SHA works under there. And we see that there was an investment of 104 billion, which was to be done within the very first 2 years of SHA working, and for this to be recovered within 10 years. So a question arises. This is so clear, and it was actually outlined by the PS of Ministry of Health on 1st October 2024 in an interview when SHA actually began or started. And therefore, a question that arises
is this your criticism finally?
Yes.
Are you getting the criticism? You said
I'm critiquing now.
Now you're critiquing it, right?
Yes.
All right. Okay, go for it.
So we see that actually working, that there is an investment. Is this investment actually working for the people or for the administrative aspect of it, that is for the government? Because there's not been any issues with this from the Safaricom, the consortium by Safaricom. However, on the ground we see that there is no allocation from the government under these 2 funds provided in the SHA Act. That is the Primary Health Care Fund and also the Critical and Chronic Illness Fund. So actually, actually 2 weeks ago, the RUFA chair, that is Rural Urban Private Hospitals Association chair, Mr. Brian, actually informed us that they gave a notice to the Ministry of Health that they will not be providing services as the private hospitals. And therefore, that is bringing us to the reality on the ground that there's actually no allocations from the government. He actually outlined that there was 33 billion debt that was incurred by the migration from NHIF to SHA. And as from 1st October to date, there is 44 billion debt that has been incurred. Therefore, where is the allocation from the government? That is a question that we're asking ourselves on the ground. Is it favoring the administration or is it on the effectivity on the ground? So I don't believe that SHA is working to this extent.
Yes. Thank you very much. Future senior lawyer, the lady in the front, just a short to speak. Please.
My name is Anne Kimberly from Kakamega County. I am a student of law at Jomo Kenyatta University too. And
please critique it. Critique it.
Yeah, and I will pick from where she stopped in critiquing it.
Yes.
Recently, Dr. Brian Lushenga was talking about SHA not working. SHA has been in line for only 1 year currently. And the private sector, the private hospitals already have a 7 billion debt. The government owes them 70 billion from SHA. They already have a debt, and this thing has been in line for only 1 year. 700 hospitals already are not providing services and accepting payment through SHA. It means the system is not working. This has been here for only 1 year. Why are we having debts? Why are we having debts, yet SHA is having deductions from SHIF? And we'll go back to the question of how much is being deducted. Let's not talk about the 2.7%. Let's talk about figures in general. If you ask a manager, you'll get something different. If you ask the CEO, you'll get something different. Why are we being given a range that SHA is receiving approximately 50-something to, let's say, 70-something billion from SHIF deductions? If it's something that is working, we're supposed to be having concrete figures.
An actual figure.
An actual figure.
Right.
They should be saying 94 billion or just something. Yeah, SHA is not working.
Okay. Let me go to this side. Where's the microphone? Since you have the microphone, go for it. And then this lady, and then I will come back here too. Yes.
Okay, good evening, the panelists and everyone. My name is Marvin Gabriel Owino from SHA County. Currently a student at the Kenya School of Law. I want to structure my comments based on 3 words that have come out in the conversation. One, my brother Innocent talked about faith, and then he talked about political bad manners. Trust was talked about, and then our sister there said that in Kenya there are many stories. So this is my story that last year I was so sick, and I had been employed sometime in 2023. So it means that automatically I was contributing towards NHIF. So this will take us to where the trust was broken. I went to the hospital. One thing I was told is that I cannot be treated. And the reason was that government will not pay. I went to a private hospital. Now, when I realized that the government will not pay because it is a private hospital, I went to a public hospital. I found a long line. I went back. I had to go back to my boss to ask for my salary to be paid earlier so that I can go to a hospital. And that's what my boss did. And that's where I lost faith with NHIF and with anything that looks like a government program for my health. So that today, if it is called SHA, I know the outcome is that if I go to a private hospital, they will send me away, and the story is that it will not be paid. I think this year, only in March, is where the president spoke to certain private hospitals, and they agreed they would be treating. Now, what the facility owner will not tell you is that when the government is not paying, they don't even diagnose. They send you away. That is the reality of what is happening to many Kenyans. So that is where the faith was lost. And faith, of course, is the same as trust. So I do not trust SHA, I do not trust NHIF, and ultimately, I do not trust the government. And that takes us finally to the issue we talked about, political bad manners. I think we must call a spade for a spade. And there are certain issues in a country that we cannot joke about. One of them is health, because you need a healthy nation to do anything. And our government, or I would say from the history of what I've seen in our nation since my birth, is that everything is politicized, including something like health. It is politicized to an extent that if it is not working, we do not want to admit that it is not working and go for something that actually works. We want to stick on it so that in the end we can say it worked. And then we want to measure everything as a political achievement. I believe something like health, we cannot joke about it and then eventually make it a political achievement that we brought NHIF or SHA that worked better than NHIF. That's the story today. Okay. It is not about health. It is about this is something that has to work better than the former so that this regime is seen as successful, and that is what we are calling political bad manners. It is a gamble with people's health. Thank you.
All right. Thank you very much. Very poignant. Just the microphone, pass the microphone here to the lady, and this lady here on your left. Yes.
Good evening.
Good evening.
My name is Adelaide Daria. I'm currently an advocate trainee at the Kenya School of Law, and I'm from Bungoma County. So my opinion on whether SHA is working, I'd say that it's not working, it's inadequate, it is insufficient, and it's also unfair. So this opinion comes from my personal experience with SHA. Last year, I had to go to hospital and I had a bill of around 50,000. And when it came to paying, I was told that SHA can only pay for the bed, which was 3,000. So out of 50,000, SHA helped me pay 3,000. And that's why I say it's inadequate and it's not working. The other point is the village from where I come from. This is in Naitiri, the Sango village. We have these hospitals called dispensaries. They are funded by the CDF. SHA has never been had there. At one time, I asked one of the village members, who's also a farmer, and they told me that they couldn't believe the direction. They couldn't believe that there's a way that the government can pay for your medication. They couldn't believe the concept of SHA, that you'd be deducted or pay 300 shillings per month, and then when you get sick, the government will cater for. So SHA does not work even in the rural areas. And last but not least, the unfair deductions. I believe the unfair deductions over the different tax brackets. It's really unfair to hear that there are people who pay 300 if you are unemployed, and then when you get to the point whereby your salary is 100,000, you pay a particular amount. For those earning $1 million, it's also a different amount. So yes, SHA is quite unfair. Yeah, it's quite unfair.
Latif would agree.
Yeah.
Fully agree.
Not quite. I think I go with what Daktari had said earlier. It's about equity in terms of contribution, but also identifying those that need support and properly having them. You know, social protection is something that's big. And we even raised it here again a couple of weeks back. Social protection from the Ministry of Labor and Social Protection, from the counties, identifying people who need support and actually offering them support. And then everybody else encouraging them to be contributors.
But I'm hearing a lot of the issues around funding. And I'm just wondering, because if we're being realistic, it sounds like we are broke as a country from all the sectors that are suffering.
Did you use the word?
It is apparent. All right. It is apparent. And I'm just wondering, and I'd like to engage Dr. Theory and any of our panelists who can chime in. Then what would be an ideal way of going around funding. There's been the question of how unfair it is to even expect people working in the informal sector to do this one annual premiums that they're expected to do. Most of people in these vulnerable groups are on survival basis, that they're thinking about their immediate needs, and that health premium becomes the last thing that they're thinking about. Is there a way to rethink then, so that we are not just talking about the problem, how we are doing the funding for this?
I think, yes, there's a way of rethinking it. And one is we must trust Kenyans to understand. Because you can hear the conversations in the room, there is fairly good understanding of what the problem is and what the possible solutions could be. So we must trust Kenyans to understand. And I will draw a good example. We're in the by-election season. MCAs, there's a senator position somewhere being contested. What is the one thing that we look at? Are you a registered voter? Is the first thing, before we can confer you the right to vote. For healthcare, like I said, there is no free healthcare. That is the first thing. The second thing, upon registration, we must go back to Kenyans. It is a politically unpalatable conversation, but we must pay. That is just the truth. We must pay. And this is a call to all of us in the room. And I'll remind us of something that Obama said when he was accepting his Nobel Peace Prize. He said, we are not mere prisoners of fate, but through our individual and collective actions, we can slowly move towards justice. And the people in this room, and they're fairly as young as I am, they will be both causative and consequential to who will be the next president of this country. So we must keep our political class accountable. And they're the ones who undertook that challenge. So they must go back and tell Kenyans, we must pay. The second thing is the model, like has been explained, also carried some assumptions. The first assumption was the informal sector must be netted to a good size. Because again, the principles of insurance are pooling risk. So as it is right now, there's quite some adverse selection that is happening. However, there were managed schemes under NHIF. Those ones were loss-making. The good thing that has happened right now, SHA has demanded of the payers of those managed schemes to first put in money in our accounts as SHA, and then we will provide service to your members, which is, I think that is a good thing. The other thing is for the providers. We have a debt of about 33 billion from NHIF and perhaps about 40 from SHA. What we are asking is, there are things I agree with him. And on this one, I will ask him to risk to see things from our side as well. And it is not a bad risk for him to take, because there's an advert that I've always liked by Safaricom, which says, when we come together, great things happen. So if we come together, and he's called himself a bulldozer, he can bulldoze his way for payments to come in, all right? But also roads are not built only by bulldozers. Kuna ile itakuja imwage maji, kuna ile itakuja weke lami, and we are all actors in this. And once that money comes, I am sure here Reverend Karaoke akilamba glucose, tutaendelea na safari pamoja. And that is what we are asking the president. Akubali hata sisi tulambe glucose, tuendelee na hii safari. And then finally, there needs to be clarity of roles between DHA, that is the Digital Health Agency, and SHA. One of them is an authority, the other one is an agency. And as an agency, you are carrying functions on behalf of someone. And my opinion is SHA needs to be in charge of its own system, so that when we ask questions, we are getting answers, because the contract we have as providers is with SHA. And the annual payments that you've talked about, yeah, the informal sector is very good at one thing that perhaps most people in government are not. That is cash flow management. When you tell a mama mboga that I need 20,000 from you, it is possible they'll give you that 20,000, but they may not give you immediately. So how do we stagger these payments? Because they have a good understanding. They know they need to be healthy. Yeah. And again, the principles of insurance. They have an unlimited insurable interest in their own health. So they will give you that money, but we must make them understand why they're giving you that money. Once those cash flows are okay, providers are going to provide healthcare, because good healthcare is like good drainage. You mustn't see it, and you must trust that when it rains, the water will flow away. The fact that in this season we know there are organizations like RUFA, the organizations like KHF, these are typically organizations that interact with government on most of our day-to-day basis. That you're hearing them out in the public is a signal that some things can be better. And we are asking the holders of this dream to also walk with us this journey, because we have a fairly good understanding of also what is happening. Thank you.
All right. I mean, if you could just also respond as you make your final remarks. You know, and later there said people in Naitiri do not trust, have never heard of this SHA thing. Chakalini, Lumakanda, Lukuyani, all those people are like, this thing does not work. So as you make your final comments, please address that to his question as well of, we must trust Kenyans to know what they want.
So one, to begin with her question about financing, the government needs to start by itself. I think, as has been said, is that we have participated as KMA and many other organizations in the dream of SHA in terms of writing what is supposed to be and what it should be and what we need. When we had this initial writing of what is needed to fund primary healthcare services, it was to the tune of 40 billion. When you notice this year's budget is about 13 billion. So, and then it trickles down to why we are having the conversation from Rufa, who are saying we are still discussing ideas. Because if you're underfunding what should be your biggest marketer, the PHC fund. When one of the participants here has said that they went to hospital and they could not get services, that's a broken promise. And when you break that promise, there is no way that person will ever pay for SHIF. So government needs to start by the exchequer-funded models, and that is PHC. Fund it to a level where Kenyans can trust that, oh, kumbe, when I go to hospital, they actually have that Panadol. So that I say, oh, then I can actually be able to pay for the social health insurance. We started this conversation by saying the SHA has been one of the, I think they score grade E maybe in communication. Because that has been the biggest issue in this relationship between the payer, the provider, and the population. Because if your population does not understand your means testing, and if it looks difficult, and if it looks like you're trying to target me or know what I own, trust you me, many people will shy away. If I cannot trust that you're going to ensure that I have social protection, I'll not pay. For the informal sector, they have groups, they have circles, they have, where are we not utilizing these places where they are used to? Because people come from the known to the unknown. If they see something is unknown, they are much more unwilling to participate. But if they come from the known, which is the circles and the groups that they have, they're much more willing to be able to pay for the services that are there. Another thing is the benefits package, and I think you had mentioned it. The benefits package is available. However, Kenyans do not know what they are entitled to. And it's usually a moving target in terms of there's an actual committee which is there, which is supposed to tell Kenyans, you are entitled to 1, 2, 3. Based on our affordability, based on our calculation, and you're able to give feedback and say, why are we not paying for this? Linda Mama, we had some level of social protection for maternity. They said we augment it, we consolidate and give some level of social protection. But in this case, where do these mothers go currently? Yes, I know we are providing healthcare services to all people, but who is paying SHIF for them, for instance, such that when they get admitted, they're there. So we have a good idea and it can work. However, there are multiple things that the implementers of the SHA dream are probably working. They're running faster than we can catch up. For instance, the claims management system. SHA will not work for the provider whose claims have been rejected 50, 60%. It is not working, because if you reject my claims and I do not understand why, and you call me a fraud, then we cannot work together. It needs to be a holistic conversation that you say, I rejected because of this, and this is how you resubmit, and this is how I'm going to pay you. And that has to happen real time. It has to be faster than it is. As you heard, I think the last conversation, the CEO of SHA said, they've rejected about 10.7 billion worth of claims. It is possible, some of them might be fraudulent, but I believe a significant portion of them are actually valid claims, which either the provider does not have the capacity or their system might be having certain challenges in accepting the system. So for us to be able to get to where the ideas have been accused of is that, one, we must deal with mistrust across. I think you've heard the young people here say SHA is not working for them because they are university students. Most of them will not have jobs. Why are they not on a social protection mechanism? It should be obvious that if I'm a university student, I don't work, I should be getting shift for free because really I cannot afford. Secondly is in terms of delays in payments. Our doctors still have money from NHIF, not even this NHIF. Before NHIF even folded, there's some money that was lost for providers and to doctors before NHIF folded. And now NHIF folded, there's still some money which the president promised in March of 2025, which has not been paid to date. That's another broken promise. And when you break promises, it means that the dream, people fault your dream and you risk a good dream actually failing because you are not honoring the promises that you made. So I think in terms of ourselves as Kenya Medical Association, when I make my last words, is that, one, the issues of payments must be addressed. Secondly, we must increase the exchequer funding towards healthcare services. We must ensure that we are asking our Kenyans nicely to pay for healthcare services. And when it comes to the system cannot work without the people. When you implement a system, it is your responsibility to ensure that the users of that systems are comfortable. For instance, the Practice 360, which is an app for doctors, I think has had challenges. And SHA has acknowledged some of the challenges that it has, and the resolution of these challenges has taken so long that the provider or the doctor is left to wonder, are we really wanting to move this dream forward?
All right.
Thank you.
All right. Thank you very much. Zaha.
I feel like there's
Would you take 30 seconds?
I wanna give you my 30 seconds.
Yes. I have to go. Otherwise, there will be no insurance for us here.
Yeah, thank you. I think for me, as we end, let me now go to the solutions. And I want to start by saying that we just have to ensure that SHA works. We don't have an option, and that is why we are here today. Number two, I think we have the best combination of leadership under the Ministry of Health currently. And I know some may disagree with me, but we have PS Oluga, who has been on this side and who is a technocrat. We have PS Modoni on the other side, and we have the bulldozer, CS Duale, who is very good at politics, and the DG. And we know that the CS is very close to the president. So I want to address just 4 areas that I feel that they are actually failing us. Yes, please.
Could you combine all of them in 30 seconds?
Yes.
So I don't want to cut you.
Yes.
All right.
You have already taken 10 seconds.
So you have 20.
Yeah, so the 4 areas, number 1 is the money. Why aren't we getting enough money? It is because the means testing instrument is not accurately assessing the capacity of Kenyans to pay. So we need to relook at that so that we can be able to generate enough resources. Number 2, the lopsided funding structure. We need to deploy more money to the primary health care. And the reason as to why we do this is because if we have more money in the preventive and promotive, then we reduce the cost of healthcare because many people do not get to the secondary, which is actually quite expensive. So on the issue of the facilities and not being able to offer services because of the debts, my advice to the government and to the ministry, they really need to come to the table and come up with a payment plan with the facilities. The high-handedness that we are seeing from the government is not going to resolve anything. So mine would be to ask the CS and his team to sit with the team from RUFA and the others so that they can have a payment plan and so that Kenyans can actually be able to access that service, because I believe that we can be able to find a solution if we can sit and reason together.
All right.
Thank you.
All right, thanks. Okay, great. I would sit here the whole day. I'm really being pressed to get out of this thing. All right, Reverend?
Yes.
Yes.
30 seconds.
30 seconds. I have to trust you.
Thank you so much. My word is as good as a scripture. I want to say this. There is no lover of SHA than Rufa. I've never found one. Because of these reasons. Number one, 88% of the people that we see, uko mashinani, they are SHA members. The insurance penetration in Kenya is below 2%, private insurance. So we deal with 88% of SHA members on a daily basis. That's number one. So we can't afford to see SHA fail. We have to support it. Apparently, we are the enemies perceived. Two, for the love of SHA, I don't know any other association that has given SHA feedback. In the last 9 months, we have given 8 feedbacks, telling them what is not working, what is working. So we just don't understand why somebody shouldn't just call a few people around and sit down and look at the criticism, if so be it, that are being given by Rufa. Lastly, we talk of registering people and sending them to hospital. Jiandikishe, go to hospital, you will be treated. Go in, go out, and you will not pay anything. On Friday, you were told you can even go to Aga Khan, you know? And this is what we want to say. Let the politician, with the same breath of telling people to register, tell them to pay. There is no free thing in this world. Right. Lastly,
those are two lastly, Reverend.
Yeah, a good preacher finishes 3 times. Now, lastly is to say that this proximity testing should be done away with. We have said we have about 25 million people registered. If you remove the 4 million from the formal sector, the payslip guys, remove another 1 million from the business people around here that are paying, we have almost 21 million people that have registered and not paying. If we remove the proximity testing and say probably they pay 500 shillings only, do you know we'll be collecting over 10 billion shillings a month that SHA has not been able to collect since inception. Okay. So we need to do this to be transparent and to sit on a table and discuss these things openly, not sideline some stakeholders. Thank you.
All right. Okay. The good preacher.
My closing remark is simple, and I'm from private sector, so I'm efficient. As the umbrella body, what we are requesting our good minister, the bulldozer, once he's back from New York, akuje tutengeneze hii barabara, tutatengeneza pamoja. Because the reason I say that is Kenyans must access healthcare, it must be available, and it must be of good quality. Those are the principles that KHF stands on. So whatever thing that is going to give them access, we are going to support it. And I don't want to believe, as a cabinet secretary responsible for health, he has such ambitions. And if those two, if our ideas and his are congruent, we are going to deliver this thing together with my members here, Rufa, Chuck, KCCB, SUPKEM, and CAF, as well as KMA. We'll deliver it.
Okay, Latif.
Maybe seen a last word. Yeah, I'll just go back into that thing. Let them accept they bungled the rollout of SHA, and can they do it better going forward? Year 2 should not be like the past 2 years.
Right. I think we've built up to the last word. And I think the answer, the question we asked tonight, is SHA the solution for Kenya's healthcare problems? And as we have discussed, this answer is a bit nuanced because most of us, if not all of us, seem to agree that the design is okay. We are having a problem on the implementation stage and operationalization.
That word.
I've always had a problem with that word. So there are things that are working. We've had massive enrollment into SHA. Of course, contribution is another story. But just the very fact that we have up to 26 million Kenyans and more, the goal is to have universal health coverage, to say that I have health insurance. That is a good. and that there are significant claims that have been paid out, and also comprehensive care as is designed with the expanded benefits. There are things that are not working. We have talked largely about the massive gap in funding. We have also talked about high claims rejection rate, and at the same time, low contributions. These are some of the things that are not yet working. So what are we saying? Is this the solution? That yes, it is the right idea, with the potential to be a true game changer. But for it to succeed, SHA needs to solve its core issues of funding and compliance. And that until then, it remains a fantastic promise that still has a very long way to go to become a reliable solution for all Kenyans. That is the last word. Thank you very much. I want to thank our panelists for joining us tonight, the entire audience. Thank you for your input and your thoughts. Co-hosts Zaha, Smart, Eric, thank you so much. My name is Sharon Omanyi. Have a good night and see you next time on The Last Word.